Welcome to Doctor in Emergency Medicine teaching podcast series. It's a set of podcasts delivered to all clinicians working in the field of emergency medicine. Make sure you will click subscribe and the bell icon at the bottom so you get notification about our new episodes. Also find our show notes below the video as well. My name is Dr. Rajan Kailanathan and I'm here with me, Dr. Swarup Valluri on this video conference. And today we're going to talk about the pediatric head injury and going to focus specifically on the management of severe head injury in pediatrics.
I think a bit of background about pediatric head injury and emergency medicine presentation. Pediatric head injury is quite common. It accounts for about 3 to 4% of children presenting to the ED. The vast majority of them are minor head injuries and do not require any further imaging or specialist consultation. However, there's a minority that would require stabilization and neurocritical interventions and management by a neurosurgical team in a specialized center. The key elements of management in the ED are to rapidly assess for severe pediatric head trauma. And prior to that, it's always important to recognize that head injury is one spectrum of pediatric trauma. And all patients presenting with trauma would need a primary survey and stabilization and identification of life-threatening issues. And it's also important as an emergency provider, especially dealing with pediatric head injury, to be mindful of non-accidental injury and have a level of suspicion to evaluate for non-accidental injury. To guide emergency providers in assessing and managing pediatric head injury, there are a few decision-making rules. We use the PCAN decision-making tool, which has been validated extensively. The notes of the PCAN decision-making rules are available in show notes. However, just as a starting overarching statement, any pediatric patient who's got a GCS of less than 15 with a suspected or known skull fracture and with altered conscious state will require emergent neuroimaging with a CT scan as an initial part. And going forward, Rajan, I think we'll discuss the management of severe head injury in the emergency department.
So management of major pediatric head injury in the emergency department, it can be challenging for non-specialized pediatric units and small emergency departments. So it's good to have a structured approach to manage these in these settings. So preparedness is very important and a key element of management of pediatric emergencies and pediatric head injuries particularly. So we can assume almost always there will be a pre-notification of some sort through the BAT call or some sort of electronic notification. So the way that I would like to manage pediatric trauma and head injury is to hand over the department to the next senior on and assemble my team and brief the team in the area where we'll be managing this patient after arrival, such as would be in a resuscitation cubicle. So once the team is assembled, there is a good mnemonic to keep in mind. It's called LIPS, L-I-P-S. So L stand for labeling and share the information that we have available to us. And then I stand for issues that address and needing to be addressed. So whatever the issues that has been already addressed by the pre-hospital team and what is our ongoing issues that we need to be addressed. We have to bring our priorities much earlier in place. The priorities in head injury is early identification of head injury and prevention of the secondary brain injuries. We will talk about that, how to do that below. S stand for supportive and specific care. So supportive care including the management of analgesia and diemetics, neuroprotective measures, and the post-resuscitative care. And then specific care with the how we're going to disposition this patient to a neurosurgical unit, whether internally or externally. We need to think about the stuffs that we need. So that is all the equipment. So we need to bring the, we have to estimate the child's weight. So the formula that I use is age plus 4 times 2. For a 6-year-old child, that would be 6 plus 4 is 10 times 2 would be 20 kilos. We all should have a weight-based color-coded ED trolley with airway, breathing, and circulation. So we have to pay particular attention to the following and have to bring out all our equipments out and have to spread it up and have a plan. So for example, our airway equipment, and that could include the type of blade that we need, the type of tube that we need, whether we do need bougie, LMA, and if in a plan A, B, C, D approach, and if we do need a surgical airway, how we're going to proceed with that. So that need to be articulated much earlier in the preparedness phase. Set up the ventilator for neuroprotective ventilation. We should think about access. So ideal to have 2 IV access, and it may fail, and we should have a plan to do IO, intraosseous access. We should prepare the normal medication that we need. So for example, normal saline, we can have 10 to 20 ml per kilogram and is prime and ready to go. Glucose, 2 ml per kilogram of 10% dextrose, again, prime and ready to go. Adrenaline, 10 mics per kilogram. We can use the 1 in 10,000 method of preparation of the adrenaline and should have 200 mics. So for a 20 kilos would be 200 mics of adrenaline, 10 mics per kilogram, prepared and ready to go. We need to think this major head injuries very likely need to be intubated and ventilated. So we need to think about our intubation drugs. So for example, ketamine, 3 milligram per kilogram, fentanyl, 1 to 2 milligram per kilogram. The intubator can choose suxamethonium or rocuronium of their choice, and suxamethonium can be 2 to 3 milligram per kilogram and rocuronium 1.5 milligram per kilogram. We need to think about seizure prophylaxis and manage medication that need to manage the increased intracranial pressure. For seizure prophylaxis, midazolam 0.15 milligram per kilogram, levetiracetam 40 milligram per kilogram, and phenytoin 20 milligram per kilogram. For to manage increased intracranial pressure, that would be mannitol 1 gram per kilogram and hypertonic saline 3% and 3 ml per kilogram. We should have an age-specific C-spine collar for C-spine precaution, but that could be difficult. If that's the case, we should have some sort of plan to do spinal immobilization during our management and resuscitation of this child. Moving on, Swaroop, would you like to take over from the initial part of the resuscitation of this child?
Thanks, Rajan. That was a very comprehensive review of our preparedness, sharing a mental model, and having an accurate understanding of what are the initial issues and what could be the potential issues that could come up in severe traumatic brain injury, especially pertaining to pediatric population that we're discussing. I'll talk about initial resuscitation. As I've alluded to previously, a patient with severe head trauma is also a patient with trauma. Hence, primary survey, stabilization, and C-spine protection are imperative. It's also important to recognize and control exsanguinating scalp hemorrhage in these patients. Applying the C-spine protection is important. One of the main issues with managing patients with severe traumatic brain injury is airway protection. We'll go through the intricacies of airway protection in a later podcast, but the important part is to ensure that there is no secondary brain injury either in the peri-intubation stage or post-intubation stage. Peri-intubation stage, managing the laryngoscopic phase and the intubation phase in a controlled setting to ensure there's no hypertensive/hypotensive episodes, and to ensure that there are no hypoxic episodes is critically important. Post-intubation, once the airway is secure, there are a set of endpoints that we can aim for to prevent further brain injury. These would be to maintain a MAP of 60, maintain saturations above 96 with minimal PEEP, Maintain an end-tidal CO2 between 30 and 35 with titration of the respiratory rate. A sodium level of greater than 140 monitored on a venous gas or formal blood test. Ensure normal glycemic status and normothermia, while maintaining the patient with a head elevated position of 30 degrees if it is safe to do so.
So thanks, Swarup. So we just have covered the initial resuscitation part and the end goals, as we mentioned. But we have to think about some specific conditions that can arise when in the major head injury patient in either in pediatric or adult. So the seizure management and identification and management of increased intracranial pressure. So when the child have a seizure during pre or post intubation phase, it's very important to immediately identify hypoglycemia and correct that. So if the blood sugar need to be measured immediately, and if it is hypoglycemia, that need to be corrected with 2 ml per kilogram, 10% dextrose as a bolus dose. And we targeting for a normal blood sugar. Failing that, or if it is seizure is not due to hypoglycemia, then we are moving into the treatment, first line of treatment with midazolam. That can be 0.15 milligram per kilogram, can be given IV or IO. This step for first initial management with midazolam can be repeated 3 times, and each of the steps can be 5 minutes apart. Failing that, we can escalate to our second line of seizure management. This can be either levetiracetam, 20 to 40 milligram per kilogram, or phenytonin, 20 milligram per kilogram. If the second line failing and we cannot control the seizure, we should escalate to anesthetize the child in order to gain the secure airway and as well as rapidly controlling the seizure. The second issue is identification and management of raised intracranial pressure. First of all, we need to be very mindful and watch for the neurological signs of raised intracranial pressure, which are in a patient with altered conscious level, any hypertension and bradycardia should alert us about increased intracranial pressure. This is what we know as cushingoid reflex. Then we are looking for third nerve palsy, which can come as ptosis or poorly reactive or dilated pupil in the unilateral eye. That should give us, again, the raised suspicion for intracranial pressure. Papilledema in fundoscopy, which could be a very difficult thing to assess in a patient going under resuscitation, and also falsely localizing neurological deficit also give us a suspicion of raised intracranial pressure. When we have a suspicion of raised intracranial pressure, we should act promptly and treat that either with mannitol 1 gram per kilogram IV or 3% normal saline 3 ml per kilogram per IV. So it's easier to remember, it's 3% normal saline, which also known as hypertonic saline, and we're going to give 3 ml per kilogram IV. We can repeat this treatment twice, and in my experience, the neurological signs mostly disappear. So our end goal of the effect of the therapy to determine a serial neurological examination and normalization of the neurology. I will give it back to Swarup to talk about ongoing management and disposition.
Thanks, Rajan. That was a good summary of the issues that would come up with patients with severe traumatic brain injury. Raised intracranial pressure, seizure activity, hypoglycemia, and temperature management are important, and ongoing monitoring helps in early identification of these situations. Going on to post-resuscitative care once stabilization has occurred, it is vigilance and monitoring for maintenance of saturations above 96% with minimal PEEP, maintenance of an end-tidal CO2 target of between 30 and 35 titrated to the respiratory rate, a sodium level of greater than 140, which can be measured on serial venous gas examinations or serial arterial gas, whichever is available, and meticulous attention to the glycemic status and to the temperature would help in early intervention and correcting any physiological derangements. In most situations, if there is no in-house neurocritical unit available, these patients would need a transfer to a specialized neurocritical trauma unit. And most often than not, while the initial CT is performed to assess the extent of trauma, it is not uncommon that any deterioration of neurological status non-responsive to therapy might warrant a second CT for assessment of the intracranial injury. Now that we've covered the main topics of management of severe traumatic brain injury in pediatric population, Rajan, would you like to summarize the key issues and learning and take-home points in these presentations, please?
So today we have talked about how to resuscitate and manage a major or severe pediatric head injury in an emergency department which may not be familiar with managing pediatric trauma. So the learning points are: head injury patients are still a trauma patient and managed as per the ATLS principle, which including primary and secondary survey and stabilization. It is very important to early identification of major head injury in pediatric population earlier in the assessment phase and institute management to prevent primary and secondary brain injury. The neuroprotection and ongoing monitoring, which are, like we said, target blood pressure specific to the age group, keeping the head up 30 degrees if it is possible. If the patient is on C-spine precaution, we can use reverse Trendelenburg. We can have loose C-spine collar, loose ETT tie, and by doing this, we can reduce obstruction and venous return from the brain, which hence reducing the cerebral edema. Maintaining saturation more than 96, maintaining end-tidal CO2 between 30 and 35, maintaining sodium greater than 140, maintaining temperature and glucose in the normal range. These are very important. Clinical identification of raised ICP and initiating management even prior to the radiological confirmation is important. And it's also very important to expedite disposition to the specific neurosurgical care for definitive management. Thank you.